Hello everyone, I'm coming to discuss today one of most common disease we may be discovered day after day, microscopic colitis. Microscopic colitis, if we are searching for the etiology, we have an idiopathic chronic inflammation of the colon and lead to watery diarrhea associated in some cases with a celiac disease, autoimmune disease in some cases, and maybe related to some drugs like non-steroidal or some of BPIs inhibitors, smoking. All of these can be induced microscopic colitis. So more common individuals who are biologically female being probably susceptible for being or having microscopic colitis. Unknown triggers abnormal collagen metabolism, dysfunctional epithelium, and this is altering the barrier function of the mucosa and lead to mucosal inflammation in addition to decrease the sodium absorption and increase chloride secretion. So it leads to secretory diarrhea. The types of microscopic colitis can be collagenous type, more common in older women who are biologically female, as I mentioned before. Dense subepithelial collagenous layer increases intraepithelial lymphocytes and the inflammatory status in the lamina propria. Lymphocytic colitis it is another type. There is no deposition of the collagenous layer as present in the collagenous type of the microscopic colitis. Only it is intraepithelial lymphocytes infiltrating the lamina propria. Diagnosis when we are doing endoscopy, the endoscopy usually normal mucosa, so it is a microscopic colitis as I mentioned. And the biopsy, which reveals that there is an inflammatory changes in the lamina propria with intraepithelial lymphocytes infiltration, dense subepithelial collagenous layer, in addition to elevation of some of biomarkers like fecal calprotectin, ESR, myeloperoxidase. All of these can be suggest that the patient have some sort of microscopic colitis. Autoantibody like antithyroid antibody, peroxidase, and the ANA anti-neutrophil cytoplasmic antibody, p-ANCA-INE or c-ANCA, anti-Saccharomyces cerevisiae. It is one of antibodies which may be present also in microscopic colitis in addition to rheumatoid factors. So how we can deal with a case of microscopic colitis? Active microscopic colitis, we can do induction therapy by budesonide 1 milligram up to 8 weeks. And if the patient enter into clinical remission without relapse, no maintenance therapy can be needed. If the patient develop clinical relapse, we can do reinduction again by budesonide 9 milligram per day. Chronic, and we are converted in our mind that this patient is changing from active microscopic colitis to chronic active disease, and we have to maintain this patient on budesonide low doses 3 to 6 milligram per day, plus minus loperamide. Some maybe add 5 amino salicylic acid as they have an anti-inflammatory effect. If there is no clinical response, other causes of the diarrhea can be identified and we are treating accordingly. Consider loperamide and cholestyramine. In some cases, when we are feel we can use infliximab as a supreme vedolizumab, and even in some cases we may need to surgical intervention for treatment of a condition like this. Thanks.